Sige, ang natabo.
Okay, good evening, Doc. Good evening, classmates. So now we're going to continue with my report with regards to drugs used to treat anemias. Okay, so moving forward, agents used for other anemias. Next slide, please. Okay, so agents for megaloblastic anemia. Megaloblastic anemia is treated with folic acid and vitamin B12. So folate deficiencies usually occur secondary to increased demand, as in pregnancy or growth sprouts, as a result of absorption problems in the small intestine because of drugs that cause folate deficiencies, or secondary to the malnutrition of alcoholism. And vitamin B12 deficiencies can result from poor diet or increased demand, but can also be due to lack of intrinsic factor in the stomach, which is necessary for absorption. Next slide. So we have for folic acid derivatives include folic acid, leucovorin, and levoleucovorin. And for vitamin B12, we have hydroxycobalamin and cyanocobalamin. Okay, next slide, please. For therapeutic actions and indications, folic acid and vitamin B12 are essential for cell growth and division and for the production of a strong stroma in RBCs. Vitamin B12 is also necessary for maintenance of the myelin sheath in nerve tissue. Folic acid is used as a rescue drug for cells exposed to some toxic chemotherapeutic agents. For leucovorin, it is used as a rescue drug following methotrexate therapy to decrease the toxicity of methotrexate or overdose of folic acid antagonists such as megaloblastic anemias. For levoleucovorin, it is the newest drug in this class and is only approved to decrease the toxicity of methotrexate caused by decreased elimination or overdose of folic acid antagonist in the treatment of osteosarcomas. Next slide, please. So this can be seen in the book, so I hope you'll read for this. For contraindications and cautions, these drugs are contraindicated in the presence of known allergies to these drugs or to their components. They should be used cautiously in patients who are pregnant or lactating or who have other anemias. Nasal cyanocobalamin should be used with caution in the presence of nasal erosions or ulcers. Next slide, please. So for the adverse effects, hydroxycobalamin has been associated with itching, rash, and, and signs of excessive vitamin B levels, which can also include peripheral edema and heart failure. These can also cause mild diarrhea. Pain and discomfort can occur at injection sites. Then nasal irritation can occur with the use of intranasal spray. Okay, next slide, please. These can also be seen in the book. Next slide, please.
Unsa pagipabot ni Minday?
Okay, so for agents for sickle cell anemia, patients with sickle cell anemia are treated with antibiotics to help fight the infections that can occur when blood flow is decreased to any area, with pain relieving activities to help alleviate the pain associated with anoxia to tissues. Hydrosar- hydro- hydrocy- Hydrocyuria is a cytotic
Next slide.
anti-anoxia. Okay, so next slide.
Kinsa ko'y ga-report ron? May I know
Okay,
kinsa ga-report?
deposit doc.
What takes you so long to read? O, dili na ka mo report? Okay, hinay ang net sa iya ha. Is there any alternative reporter sa inyo ha? None. No alternative reporter for the group on CVS. Okay, so you will have the same grade anyway. So cardiovascular, Bermudo, Candeliza, Diposoy, Grifon, Lobitania, Marigomen, Moreno Lacalle, Sabanal, Tinapa, Villado. So all these do not know the other reports. Okay, so we will stop it now. Okay, nobody is an alternate reporter for anybody. So ang ilang nga balaod sa ilang grupo, kana imuha ra na siya ako'y labot na na.
Good
Okay?
evening, Doc.
So,
I will
that's it.
act as a substitute, Doc. Okay, so hydrocyuria. Oh,
Duha ka buok imong gi-on nga gadget mo na mo echo.
ay, wait.
Next slide na, sige, saman.
Okay, so for hydrocyuria, so it increases the amount of fetal hemoglobin produced in the bone marrow and dilutes the formation of the abnormal hemoglobin S in adults who have sickle cell anemia. This results in less clogging of small blood vessels and painful anoxic effects associated with RBC sickling or stacking. So for
So
the
what do you mean by sickling, Inday? Wala pod. Okay, so kay gibasa ra niya. Okay, never mind that. Next slide.
sickling, Doc,
Next
is
slide.
when so for the adverse effects, hydroxyurea is a cytotoxic and is associated
Hydroxy.
hydroxyurea is cytotoxic and is associated with adverse effects
Next
associated with the
slide.
okay. So for this is the clinically important drug-to-drug interactions. So there is an increased risk of uric acid levels if this drug is combined with any uricosuric agents. If this combination must be used, those management adjustments rather will be needed for the uricosuric agent. So this is the drug, and this can be found in the book. So you can just scan it. So that ends the report for drugs used to treat anemias.
Okay. So, naya kong i-send sa inyo ha. Please post this ha. Naya kong i-send sa inyo ha. Sa ato nga group chat, I mean. Uy, wala man ta naka-open. Please, post an emoji sa ato ang group chat, be. Okay, first we're going to discuss regarding the coagulation. So palihog ko no ko kuan be, palihog ko post sa kanang naay araw-araw diha diagram sa coagulation nato. Okay, this is it. So again, for coagulation, first effect of, I told you the first reaction of our body to injury, ang imong blood vessel will constrict. It will undergo vascular spasm. Okay, this vascular spasm is mediated actually by your thromboxane A2. Thromboxane A2, as we have discussed already, is an inflammatory mediator, itong thromboxane. Okay, if you can still remember that. Now, this is not the first step of your coagulation. This is not yet coagulation. The first step of coagulation is your platelet aggregation, which we have already discussed. Now, how will the platelet aggregate? With tissue injury, there will be release of your thromboplastin. Okay, and then again with tissue injury, there will be what we call this. There will be activation, or there will be adherence or adhesion of your platelet on the rough surface of the injured vessel sa wall. So rough magyuna, masamad ka di ba? Rough man ang samad. So diha mo tapot ang inyong mga platelets, after which mo form siya daghan, magtapot-tapot ang mga platelets. That's called platelet aggregation. Now, the platelet aggregation will already block or plug the injured vessel. Iyan na siyang i-plug. So, di na mo pa dahil bleed. Kaya ni-plug naman yung mga platelet aggregates there. So, after platelet aggregation, there will be thrombin formation. How is thrombin produced? Now, muna ni mitabo. With injured blood vessel, there will be release of your thromboplastin. Automatic na ha, with the help of calcium, there will be release of your thromboplastin. The thromboplastin will now catalyze the activation or the formation of your activator of your prothrombin. Again, your thromboplastin will now cause activation of your prothrombin activator. Okay, now the prothrombin activator will now catalyze the activation of your prothrombin to become thrombin. This is actually the second step of your clotting mechanism, when your prothrombin will become thrombin. Now, who is responsible for activating your prothrombin to thrombin? Your prothrombin activator. Now, where does this prothrombin activator come from? From your thromboplastin, which is activated upon tissue injury. So, muna yun na, araw-araw na, ha? So, this is the second stage already, thrombin formation. Now, this thrombin is a soft clot. It has to be laid out with a lot of fibrin, kay soft clot pa man siya, dali raman siyang matangtang. So, it has to be laid out with fibrin. Now, next comes the third stage. This thrombin, by the way, will be the one to cater the activation of your fibrinogen, which is clotting factor, say fibrinogen, clotting factor 1. Your fibrinogen will now be activated to become fibrin. Fibrin is already a solid clot. So enough na, solid clot na siya. But please take note, with this fibrin, which is a solid clot, your lumen of your blood vessel is already blocked halfway. Kaya lagi na amay, di ba, naman ito ni-plug ang mga platelet, gaburot siya, butangan pa ni thrombin ni burot siya samot. Now, the burot inside your blood vessel will actually block the flow of your blood. So, it is not good. So, yes, it clots it plugs the hole the injured vessel, but in the end, it is not good for the flow of blood. So what should your body do? Your body should lyse the excess clot, yang ihiliso na excess clot. So that ang mabilin ba will be the normal blood vessel wall na lang with the fibrin. Wala na tong excess nga clot. So this is where fibrinolysis would start. So this is actually the fourth stage. The fourth stage is lysis of your clot or fibrinolysis. Now who is responsible for the lysis of your fibrin? It is your plasmin. Una-una din ka nga, hala, asa naman gikaning plasmin ron? Kalit naman ni gawas niya. Go back, tanawa. With injured tissue, there will be activation, there will be release of your TPA or your tissue plasminogen activator. Your tissue plasminogen activator will now catalyze the activation of your plasminogen to become plasmin. Now, it is your plasmin which would catalyze the lysis of your fibrin clot to become your fibrin split product. So mahilis ang imong nga clot. Ang sa mabilin kato na lang imong sa wall nga ni clot sa wall. Di na to siya mahilis og samot. Okay? This is a check and balance para walay mahimo nga thrombosis sa sulod. Now, please take note of these steps because these are the steps that you are going to block with regards to treating your clotting mechanism or what you are going to enhance if you would cause clotting. Kung doon na kay bleeding tendencies pananglitan ron, ga-bleed ka diha. So sa bato nimo, you promote clotting. Kung ikaw po daghan kang thrombosis gi-form sa imong lawas diha, ga-thrombose sa imong mga tissues diha, ang imong mga blood vessel. What should you do? You have to antagonize or you have to what you block this clotting mechanism. Kung ana na check and balance naman na siya. Okay? So again, extrinsic and intrinsic factors, these are the factors. You don't have to worry about that. Now, with regards to your intrinsic pathway, it will be your plasma or activated plasma plastin time. Whereas your prothrombin time will be your test for your extrinsic factor. By the way, your prothrombin, your vitamin K dependent factors are your factors 9, 10, 7, and 2. Okay? Vitamin K dependent factors, factor 9, factor 10, factor 7, and factor 2. Again, these are your vitamin K dependent factors. Now, vitamin K is synthesized in the liver, which means if these vitamin K dependent factors are deficient, therefore your liver is deficient in manufacturing your vitamin K dependent factors, which again would mean that deficiency of your vitamin K dependent factors would mean deficiency of the synthetic function of the liver. Again, because vitamin K is synthesized in the liver. And again, because clotting factors 9, 10, 7, and 2 are your vitamin K dependent factors. Do you understand that?
Yes, Doc.
Okay.
Yes, Doc.
Umuna. Vitamin K dependent factors 1972. Then your vitamin K is synthesized in the liver, which means vitamin K will signify the synthetic function of the liver. Simple na kay na. Bukuhaan mo og prothrombin time. If your prothrombin time, sa ito pa mo, nino sa mimita mo diay, if your prothrombin time is low, sa ito pa doon na kay bleeding tendency, right? So what are you going to do if your prothrombin time is low? Anybody? Lagos. Present si Lagos? Absent. Absent si Lagos.
Excuse me, Doc. Si Miss
Ah,
Lagos, Doc, kay earlier ni chat to siya nga, if ever na ay kuan, Doc, kay gahina day ang net, Doc.
okay.
Kitagakalo man sila,
Tahom.
Doc.
Hina po imong net po tahom.
Doc? Okay ra, Doc.
Okay. So, karon,
Yes, Doc.
answer my
If,
question.
yes, Doc. If ever, I think lang, Doc, I'm not sure, Doc, but if ever ang prothrombin is low, then
Hmm.
i-increase, Doc, ang ang blood clotting, i-agonize.
Ka-weird ba po? Very vague kayo nga ka-answer. What will you do? Go direct to the point.
I-agonize
Ha?
ang blood clotting.
Agonize? Miss Halim, you give vitamin K, correct. Ato naman ang giisgutan na prothrombin time. Ang atong gamiton kung synthetic function sa liver. Okay? So you give vitamin K if your prothrombin time is low. Inaan naka-simple. Okay? So I gave you an assignment regarding which one is to monitor with regards to warfarin and your heparin. That you have to know. Which means sa inyuhang kuan, inyuhang nga ngalan ini blood ko sa ngalan drugs used to treat hemorrhage or drugs used to treat thrombosis, so you would play on this mechanism only. Kana ra gyud siya nga diagram inyong paluhon ana. Okay? So, unsa man may tabo. Now, naamagod ni siya po'y mga with regards to your platelets, ha? With regards to your platelet aggregation, when the platelet changes its shape sa iyahang pag-adhere sa surface, it will cause degranulation. Okay, sa platelet. Now, pag degranulate sa platelet mo, it releases your aggregating substances, which are your ADP and your thromboxane A2 and your serotonin. Okay, mauna ni mahitabo. Nganong gi-mention ko na ko ng ADP ninyo because most of the anti-platelet drugs, if you don't want the platelet to act, you use an ADP pathway inhibitor. Okay, that's why I mentioned the ADP here with regards to the degranulation of the platelet producing these aggregating substances. Now again, di ba ang platelet mag-aggregate siya dito? Now, some of those will degranulate and will release aggregating substances, which are your ADP or adenosine diphosphate, your thromboxane A2, and your serotonin or your 5-HT. The same animal na serotonin or 5-HT. Ha? So, mo hitabo. These are actually constrictors and it will increase platelet aggregation. These are the three substances, ADP, thromboxane A2, and your serotonin. These are the three substances that are powerful constrictors and it increases platelet aggregation. So the more, the platelet will aggregate with that. Ako nang specify again because your ADP will be used in the treatment of your anti-platelet if you don't want clotting to follow. Okay, now, sa pailain, na vitamin K, intrinsic factor, extrinsic factor, you already know that. Then, we go now to the drug. So you again, I told you, you just have to know whether these are direct or indirect thrombin inhibitors. So when you say direct thrombin inhibitors, it binds to, when you say, again, direct thrombin inhibitors, what you are going to do is to directly bind to your thrombin to inactivate it. Or you inhibit the activation of your thrombin. Okay? So again, for direct thrombin inhibitors, you directly inhibit the thrombin. Kani siya tanawan na ganun thrombin. So di ninyo ipa-form og thrombin. So your prothrombin activator inhibitor, these are actually inhibitors of your thrombin formation. If you inhibit your prothrombin activator, look at the words there. Prothrombin activator. If you inhibit that, you don't activate your prothrombin to become thrombin. Okay? Again, so examples of these direct thrombin inhibitors are your katong mga Hirodin, Bivaloridin, etc. Now, your Hirodin, by the way, is the one that is from your leech. Na. Okay? You-mention po ng mga argatroban, similigatran, those are your direct thrombin inhibitors. If you directly inhibit the thrombin by occupying its receptors. Now, let's go to the indirect thrombin inhibitors. What are these indirect thrombin inhibitors? It simply are those that binds to your antithrombin. So that means if you bind to the antithrombin, you promote the activity of the antithrombin. Ang iyang i-bind nimo ang imong antithrombin ha. Dili ang imuhang activator sa thrombin. Your antithrombin. So it promotes the activity of your antithrombin. So it accelerates the complex. So which means it inactivates your thrombin formation. So indirect siya. Kaya dili mo siya sa thrombin receptor mo bind. It will bind to your antithrombin, promoting its effect of the antithrombin. Nakuha ha? It is, kung indirect, dili ang thrombin receptor, ang antithrombin ang iyahang gi-act. Okay? Bali, it facilitates the action of the antithrombin. So what are your indirect thrombin inhibitors? These are your heparin, which a core mechanism of action is an indirect thrombin inhibitor. It accelerates your antithrombin activity. Na, mga fractionated heparin, basta takata ng klaseng heparin. And with heparin effect, of course, you monitor your APTT, whereas for your warfarin, you monitor for your prothrombin time. So kung musaka gani maayo imuha nga mumubugay mayon yung prothrombin time, meaning duna nay adverse effect. Bali duna kay daghan na nga nadaghanan na ka within you have toxicity of your warfarin. Warfarin toxicity kung deficient na ka og pro time. The same is true with your heparin sa imong APTT. Okay? Activated partial thromboplastin time, your APTT. So those are the direct and indirect thrombin inhibitors. Okay. So, unsa pay lain? Now we go now to your mechanism of action of your warfarin. This does not belong to your other for the direct and indirect. These are for the others na. Okay? Now, your warfarin blocks the gamma carboxylation of your vitamin K dependent factors. Okay. Okay, ang iyahang action again, it blocks the gamma carboxylation vitamin K dependent factors. So, may action. Okay, what are the preparations of vitamin K? These are your phytomenadione, your menadione, phytonadione, muna yung ipanghatagan. Now, let's go to your, again, this will reverse your warfarin toxicity, ha, imong vitamin K. It will reverse your vitamin K toxicity. So, muna siya imong treatment. So, which go now to your fibrinolytic drugs. So, di nakaganahan po nga daghan kayong clot. If ever, na-stroke ka, kay tungod na clot sa sulod. So, you stimulate fibrinolysis. What are these? Okay? Now, first is your mga enzymes, your streptokinase, urokinase, basta ka itong mga enzyme diya. These are actually plasminogen activator in short. Okay? Now, this catalyzes the formation of your plasmin, which means these are plasmin activators or mo yung pagkag plasminogen activator pwede ra pud gihapon. Okay? So these are tissue plasminogen activators, agonist, and or mo yung plasminogen activator or yung plasmin activator, these are the same animal. If you increase the plasmin, you increase the lysis of the clot. Okay, panlitag na stroke ka, you use this. If the cause of the stroke is thrombosis. Now, a platelet na ta, dito sa platelet. Again, aspirin. Aspirin inhibits the synthesis of your thromboxane. Irreversible na. Once you give aspirin, it will cause the death of your platelet. Yung aspirin. So, mayroon ka nga, maunsa naman wala kay platelet. Yes, it will. Whatever platelet is na-attach sa imong aspirin, wala gina siya. This is cyclooxygenase inhibitor may mga aspirin. So, unsa may metaboron? Magpaabot ka until sa nga mutubo og lain nga maghimog lain nga platelet. And that will be available. Another one para activation na pod. Okay? So, again, irreversible lang iya nga binding ha sa imong mga aspirin to your platelet. So, ang platelets are used nowadays sa mga tigulang as blood thinners para dili kay mo clot ang dugo sa mga tigulang. Because nowadays, magkagulang gani ka, magkalapot mo na yung dugo. So you don't want that to happen, nga lapot kayong dugo, kaya makakos po nag-hypertension kung imuhang dugo very espeso kaayo. So, buhaton sa mga doktor, give low dose of aspirin to the elderly para lasaw gamay ang dugo. Okay? Now, ADP now. This comes your ADP pathway inhibitors against anti-platelet ni siya gihapon. Your mga clopidogrel, ticlidopin, muna siya ADP pathway inhibitors na itong giingon. You already know the effect of ADP, ha? Muna to siya. It causes platelet aggregation. So if you don't want the platelet to aggregate, you give your platelet ADP pathway inhibitors for platelet. These are your clopidogrel, ticlidopin, mga inanatanan. Okay? So, mauna na to siya, fibrinolytic, we're gonna, now, let's go to your inhibitors na again sa inyong fibrinolysis. Now, you can give your aminocorporic acid. I told you to look for the function of your aminocorporic acid. It inhibits your activation of your plasminogen. So, walay plasmin nga form. You get that? So walay fibrinolysis ma-form if walay plasmin. The plasmin catalyzes fibrinolysis. If walay plasmin ma-form, walay fibrinolysis mahitabo. If you want to use it, if you don't want, kay gablid na imong pasyente, kung gablid na imong pasyente, you don't want the patient to die from bleeding. So you can give aminocorporic acid, which inhibits the lysis of your clot because it inhibits plasmin formation. So ana ni, please study this diagram because you will be asked about these effects. Unsay mahitabo, will it be causing hemorrhage or causing clotting? So ana mahitabo, ayag libog-libog baga inyong life. Okay, so those are your disorders of coagulation. Now, drugs for coagulation. Let's go to your drugs for anemia. Now, we have your iron that was well discussed. So, of course, iron is necessary for the formation of your red blood cells. So, unsa may tabo karon ang imong iron deficient? Wala na ni. Please remove this screen na to. So, unsa may tabo kung deficient ang imuhang iron? You will have imong iron, imuhang dugo lasaw, gagmay imuhang blood cells, o pale pud ang imuhang dugo, dili kay siya red. So, microcytic means gagmay ang cells. Hypochromic means dili kayo pula ang imong dugo. So, the opposite of that is macrocytic o hyperchromic. Okay, macrocytic dagko nga cells. Microcytic gagmay nga cells. Kung ikaw ron, kung deficient ka og nutrients, unsa may tabo nimo? Dako ka or gamay? Obviously gamay ka. So microcytic kung deficient ka og iron. Kung unsa ang kapulahon sa imong dugo di ay unsa mahitabo kung deficient ka og iron? Obviously it is hypochromic. Dili kay siya pula. It will never be hyperchromic kay deficient maka og necessary things, necessary nga mineral. Okay, that's about it. So the transport form of your iron is called your transferrin, and the stored form of iron is called your ferritin. It's very easy to memorize the mga iron preparation because it is made up of ferric, ferrous, mayonana. And then, it is the ferrous form that is easily absorbed sa atong intestine. So most of the preparations sa market are in ferrous form. It was discussed already in sa atong population that needs more iron because of the need, like mga pediatric patients, nga gatubo pa, those who are menstruating, those who are pregnant, that was mentioned in the report. Okay, so iron preparation mo na to siya. Then you can have iron toxicity kung, I think I mentioned already iron toxicity sa inyo when it is deposited sa inyong chronic iron toxicity, will be deposited ang iron sa inyong heart, causing hemochromatosis. Not only the heart, also the liver, sa mga spleen. Hemochromatosis ang condition. Okay, so iron toxicity, unsay tambal gani? Deferoxamine, defacerox, basta na mga ferro na iron na siya. And please take note, your iron cannot bind to your charcoal. It cannot bind to charcoal, activated charcoal. So you cannot give activated charcoal to decrease absorption of iron. Remember hemochromatosis. Let's go on to vitamin B12. Vitamin B12 is your hydroxycobalamin. Okay? Now, there are two active forms, your hydroxyadenosylcobalamin and your methylcobalamin. Methylcobalamin is the more active one, more important that we are going to discuss. But as long as you have cobalamin or methylcobalamin and vitamin B12. By the way, you need intrinsic factor to absorb vitamin B12. You need intrinsic factor. If you don't have intrinsic factor, you cannot absorb vitamin B12. Now, where is intrinsic factor produced? Intrinsic factor is produced sa inyong parietal cells sa stomach. So, if you remove the part of the stomach na produce a parietal cell, even if you take a lot of vitamin B12, still it cannot be absorbed. Why? Kaya wala may intrinsic factor lagi. So, you need intrinsic factor before you can absorb vitamin B12. So, what cells produce intrinsic factor? It is your parietal cells. The same cell that produces your hydrochloric acid. So, the parietal cells produce two substances, hydrochloric acid and your intrinsic factor. Okay. So this type of vitamin deficiency or iron deficiency, anemia is now called macrocytic anemia. Macro na rin sila. Di na micro pa rin sa iron. Okay, macrocytic anemia na siya. So, kung wala kay vitamin, kung daghan kag vitamin B12 nga giinom, unya wala kay intrinsic factor, dili gihapon ka ka-absorb sa vitamin B12. You need intrinsic factor. Okay? So what if daghang kang intrinsic factor pero wala kay vitamin B12 gitumar, the same thing, magka vitamin B12 deficiency gihapon ka. These two goes hand in hand. Okay? So, pero na specific name kung intrinsic factor deficient ka, this is called your pernicious anemia. It is still a type of macrocytic anemia. Intrinsic factor deficiency ra ng kuan ha, kanang pernicious anemia. Intrinsic factor. But obviously, if you are deficient in intrinsic factor, you become deficient also with vitamin B12. Kaya lagi, mo manay mo cause sa absorption of vitamin B12. Okay, so be sure to know what are the sources of your vitamin B12. Okay, which are your, of course, your meat, the eggs, dairy products. These are your sources of your vitamin B12. And vitamin B12 is also called your extrinsic factor, as opposed to the intrinsic factor secreted by your parietal cells of the stomach. So how will you differentiate now the macrocytic anemia caused by B12 deficiency and your intrinsic factor deficiency? Simple. This is called your Schilling's test. Okay, remember that, Schilling's test. You search on the spelling of the Schilling's test. Now, how do you do that? Your Schilling's test. And how will you differentiate now the macrocytic anemia produced by either B12 or intrinsic factor deficiency? Come on, eh. If you don't know the cause of macrocytic anemia, you give vitamin B12. If miayo imong pasyente naayo ang iyang anemia by giving vitamin B12, that means it is vitamin B12 deficiency anemia. That means naara kay daghang intrinsic factor kay naayo man ka. But if you give vitamin B12 and the patient continued to have macrocytic anemia, that means the deficiency there is your intrinsic factor. Diba simple na pag-differentiate? And that is not vitamin B12 deficiency anemia na. That is called your pernicious anemia. That is how to differentiate megaloblastic anemia caused by B12 or your intrinsic factor deficiency. Now, let's go to folic acid. There's a folic acid is also necessary for the development of your red blood cell. Specifically, your folic acid is necessary for the formation of your neural tube. Again, neural tube ang folic acid. Folic acid is, by the way, necessary for the formation of your DNA sa inyong sela, DNA cell. That's why most of the drug that causes inhibition of your DNA synthesis are folic acid synthesis inhibitors. You will know a lot of your folic acid synthesis inhibitors when you go into, wala, di nursing man mo. But anyway, ana, if you want to kill the organism, if you want to kill the cell, be it your own cell, cancer cells, or bacterial cells, or whatever, fungal cells na, if you want to eliminate them, you can actually interfere with the DNA synthesis by inhibiting the folic acid, because folic acid is necessary for the synthesis of your DNA of the cell. Okay? So that is with your folic acid. Again, what is the use of folic acid? It's for neural tube development. Why did they recognize folic acid now? Because they noted nga, children of mothers who are lacking in folic acid develop neural tube defects. That's why most, if not all, the vitamins given for pregnant women contains folic acid. Aside from your iron, ha? We have multivitamins, iron, plus folic acid or with folic acid. So kung mga Materna, FA, na kay madunggan ana nga mga drugs nga FA, that is folic acid. So it is fortified with folic acid already. Okay? So that is with your folic acid, mga anemia na niya. And of course, aside from those mga vitamins and minerals that we are mentioning, there are causes of anemia pod nga due to problems of your red blood cell. Nawa na kami na kung problema ang your red blood cell. O imo pong sickling of the cell, kanun letter C, sickle shape in yung cell, that is a big problem. Why? Because if the cell is letter C ang shape sa inyong cell, dali siyang ma-block ang inyong gagmay nga blood vessel. If ma-block ang inyong gagmay nga blood vessel, ma-obstructed ang flow sa blood. If ma-obstructed ang flow sa blood, it will cause pain on the muscle distal to the obstruction. So that is called your sickle crisis. Sickle crisis, if you experience pain distal to the area of obstruction or distal to the area of sickling, how will you minimize the sickling of the cell or the clotting of the sickled cell at the area of your smaller blood vessel? How will you prevent that? Number one is to hydrate the patient. You know what is hydrate? Give a lot of fluid to the patient. Hydration is the number one thing. So to prevent sickling of the cell. And of course, it was hydroxyurea ganiha mentioned as the treatment to prevent sickling of the cell in sickle cell anemia that we mentioned ganina. Okay, so that is the very basic of your clotting and the very basic of your anemia. Okay, so take note of the drugs basing on the explanation I gave you on the pathophysiology or development of your anemia and your mga sa to clotting, thrombosis, hemolysis, anemia, mga unsa pa to lain. Okay, so you may go now.
Thank you very
Unsa
much.
Thank you,
kay
Doc.
Fine, thank you.
Saturday ang ato ang
Thank you,
kuan.
Doc.
Thank you, Doc.
There,
Thank you, Doc.